everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Deloitte. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion, and we will get to them at the end. Also, stay tuned immediately following the discussion to watch our expert mixologists Natasha and Rich show us how to make a refreshing cocktail and mocktail combo. And with that, I'll throw it over to our moderator who joins us from Deloitte, Pete Mika.
Good afternoon, and thank you all for your time today. I hope you're all safe and secure. A sincere thank you to our partners at Health and to Steve, Nina, and Nancy who have joined us today to help us really think about investing in a crisis. What is the future of health and how should we be thinking that in that context? I'd love for each of our participants, for those who don't know me, my name is Pete Mika. I lead our national health technology practice for Deloitte, and very excited to be with this group once again. I'd like each of the participants to give a brief sense of their background and what their focus is. We'd love to really keep this focused on the future and getting all of us to think about how do we invest in the future of healthcare and the context of COVID-19? What's changed? What short-term impacts have occurred? Are the changes sustainable? Will they continue? So I'd love to start perhaps with Nancy. Take us out. Give us your better perspective on what's occurred.
Great. So thank you so much for having me. It's great to have just great moderation. I've been on your panels before, and it's always been terrific. Thank you, Peter, and thanks to the health team. This is exciting to be here and beginning to talk about the future. So I think a lot of us have been doing panels where we've been talking about our response to COVID, and now we can look beyond the response and think about the opportunities in the healthcare world. So I come from a firm called Oak HCFT. We're a venture capital firm based in Connecticut, and we're focused on insurmountable problems or problems that have been insurmountable, undeniable problems that are all about cost and quality. So we're a $1.8 billion fund, and we have been focused on trying to deliver care at scale that will really move the needle. I'm sure we'll get into the details about COVID and exactly what we see in the future, but we'll get into the details later, but I would say we think about it in at least three threads. One is just keeping people safe. So a lot of focus on the return to work programs, and we'll talk more about that, about the ability to take care of patients in the backdrop of COVID, both in terms of infection, as well as all the new patients that are coming into the rank and file. And then a tremendous amount of opportunity on how to deliver care differently, how to go virtual first. And then of course, a lot of details on supply chain and what it's gonna mean in the future to think about everything we ever taught everyone about just-in-time supplies, sourcing in China, everything is on the table.
Great, thank you, Nancy. Nina, how about your thoughts?
Great, so thanks to Health, and Pete, thanks for inviting us to join. And I have to say, Nancy and Steve are two of my favorite interlocutors in the business. I learned a great deal from both of them. So I'm excited for our panel. I'm Nina Shelson. I'm a general partner with Canaan. We also have offices in Connecticut, but we're actually a bi-coastal firm. So we're in Connecticut and New York, as well as San Francisco and Menlo Park. So we've had an interesting lens on the hotspots of the epidemic. We invest not just bi-coastally or across the country, but also across sector. About 60% of our investments are in technology across consumer, enterprise, fintech, frontier tech, and about 10% are in healthcare across biopharma, a bit of med tech, health IT, and digital health. And we are investing out our 11th fund, which is an $800 million fund. And we're quite active in both looking at new investments as well as supporting the existing portfolio through this. A significant part of what we're doing in healthcare is biopharma and the biopharma supply chain, and supporting both through therapeutic platforms, as well as the commercialization and supply chains on the software side. but certainly in our digital health and our enterprise software facing the healthcare space and our tech-enabled services, we're thinking very much about which of the changes that have happened are going to be long-term changes, whether those are catalysts to virtual or telehealth services, changes in the provision of care, the disruption on the provider side and the consolidation that may come, because there are a lot of have and have-nots that are going to be coming out of this on the other side among hospitals and providers and nursing homes and the like. And then what are the long-term ramifications of unemployment, changes in the employer-provided health insurance space, and also consumer behavior and how we will play into those trends in the mid and the longer term. So really looking forward to talking together today.
Great. Steve.
All right. Yeah, no, thanks, Peter. Thanks, Health. I agree with Nina and Nancy, two of my favorite people to shoot the shit about healthcare with. So thanks for having us here today. I work for Bessemer Venture Partners. I'm a partner at the firm. We are a global venture capital firm. We have offices in Boston, where I'm based, New York, San Francisco, India, and Israel. We don't have an office in Connecticut, but I hail from Hartford, Connecticut, so I have some ties to that wonderful state. We've been around since 1911, actually. We're technically the oldest venture capital firm in the world. And I think it's really interesting that we're here, and I look forward to talking about the future post-COVID. But if you think about it, Bessemer actually went through the last global pandemic in 1918, and we got through it. And if you think about it as it relates to healthcare, I kind of think, a lot has changed. We've gone through a whole digitization of our industry, but a lot really hasn't changed, right? It's still it's a system driven by in-person visits, by reactive care, by data that's not widely shared, and frankly is often siloed. Things that other industries that we at Bessemer invest in don't experience, right? And Bessemer invests in a lot of areas other than healthcare. So I always tell my partners, healthcare is about 20 years behind every other modern industry in terms of its adoption of technology. And I think as we sit here today, the real question, which I know we'll talk about today, Pete, is, are we going to change that system? Is this the moment that it sort of an in-person based chassis for delivery of healthcare changes to a technology based chassis for delivery of healthcare? And it's not just about the way healthcare is delivered or consumed by patients, by hopefully who are now going to be called consumers, but it's also about the way the healthcare is paid for and the incentives that are divvied out in terms of how the care is delivered. So I think there's a lot of interesting discussion to have today about the future of where our industry's going to be after COVID.
Yeah, no question. I mean, look, our perspective at Deloitte is that, there's been an emergence of technology in the consumer, but clearly COVID-19 has accelerated that dramatically. The question I have before you today is, and a lot has been said about, telehealth, telemedicine, virtual health, and all the acceleration that's occurred in the last 3 months. But is that really sustainable? Or do people just want to go back to normal the way they used to be? And from your perspective, are we going to miss out on an opportunity, to really change the system, accelerate the use of technology, and have the consumer be at the central part of healthcare? Nancy, your thoughts would be great.
Yeah, every one of these topics could be a webinar. So this is a great topic. We've been investors in virtual first companies since the beginning. And it was amazing to see the acceleration of that model through the change of a couple of things, which I think everyone knows about. One is just the removal of the financial and regulatory barriers that existed. So one being able to bill at the same level as an in-person visit, and then the ability to treat patients across state lines. These were huge changes that were made. And I think we could debate, will those swing back? I'd love to think they won't swing back, but there's a lot of people who have a lot invested in pushing on those laws and pushing on those regulations. But I think everyone has seen that this has improved access, which is absolutely the #1 key thing that we've been trying to do as a nation for a long time. I think you're going to see it's not all created equal. You have telemedicine coming in the form of, I'm in Boston, based in Boston. I've got some tried and true delivery systems here, like Partners. And as a member of the Partners family, I've been getting calls saying your visits from now on, your particular visits are going to be virtual from now on. And they told me about this new innovation called a portal, which I say jokingly is not a new innovation, but for them it was a new innovation. So they are absolutely going long-term with some of their chronic patients to deliver care virtually. It's also opened people's eyes to the ability to go primary care through virtual mechanisms. And it's also very quickly advancing not only the telemedicine visits, but putting monitors in the house so that you can do most of the things that require laying hands, looking in the ears, listening to the heartbeat, looking in the throat. And then also doing things like home test kitting and trying to move as much virtual as possible. And I think it's going to be a little bit of a not Uber-like, but do you remember the first time you ever used Uber and someone tried to explain it to you and you couldn't quite figure it out and then you just did it and you're like, this is very simple? I hear the same things about virtual primary care and virtual care overall, which is, wow, I tried it and it actually worked well. We're going to see some shifting back, but I think it's forever changed.
I think Nancy, Steve's point about healthcare being 20 years behind, I think the word portal is about a 20-year-old term that healthcare is trying to bring forward now. But I think an important consideration, I think, is fee-for-service reimbursement for primary care telehealth under CMS is unsustainable. We simply, as a nation, cannot afford that. So even though that's been a reasonable thing to do under COVID crisis decree, it is not something that is affordable and sustainable at that full in-person visit level. It can work if you're in a capitated system like a Kaiser that's been doing 50-60% telehealth primary care on an ongoing basis pre-COVID, and it may work within a partners panel, but it's not likely to work for all Medicare outside of an MA managed panel. So I think there's a real tie-in to the full reimbursement level that's important to consider there going forward.
Yeah, I think Nina brings up a really interesting point, which I want to come back, sort of tie the 2 points. Like, you know, I mean, the point that Nancy made, I mean, on-demand expectations are about 5 to 10 years old in every other part of the economy, right? I mean, we've been using, apps and gig shift economy for a long time. It's here in healthcare. It's taken Sisyphean effort to get there. I mean, all the things that Nancy talked about, AMA and medical associations on the state level fighting it, reimbursement issues, regulatory issues. Could you prescribe? I mean, that was a slow climb up the hill that took about 10 years in the making to get to. And I think, frankly, there were companies like Teladoc and Livongo that were already doing these efforts. And the thing that changed with COVID, which is the hardest thing for tech companies and startups to do, which is actually to generate consumer demand, right? Consumer demand, if you want to try to push people to use something, it's like hundreds of millions to billions of dollars of marketing, right? And we've seen this with some of these companies like Uber and Lyft. They just, raise huge amounts of capital to generate that. It's really hard to do, to change behavior, as Nancy was saying, people getting comfortable with using it. And I think COVID, the fact that you couldn't visit your doctor, changed that in an instant, right? And we don't have to go all the way there. I remember interviewing Jason Gorovich like 2.5 years ago when he told me Teladoc, the average penetration in their book was something like 3%. And I thought, Jesus, and their best customer at that time was like 20%. And I thought, oh my God, he's got like inherent growth in his existing book of business to go from 3 to 20%. And I don't think we have to go to 100%. I think if we shift 20% of the economy or of the healthcare economy to virtual visits, that's a $600 billion industry. Most of us would drool as venture capitalists to invest in an industry that large. And but Nina makes a really good point to tie it out. She makes a really good point, which is right now it's fee for service, and that's not sustainable. And my hope for telehealth is actually that's the greatest chassis for the fee for value movement, because frankly, it's the cheapest way and most effective way, and probably the most coordinated way to manage chronic care patients and others. And so my hope is that, again, the incentives that exist today, which is to actually for health systems to bill, to change those in-person visits to fee-for-service visits via telehealth because it's cheaper, right? And you can do it in off hours. My hope is that that's not actually taken advantage of and that telehealth has a scorn on it because of what Nina said, because it will quickly grow to crazy levels and soon be audited, right? And that would unfortunately reverse a lot of my hope, which is that telehealth is the chassis by which we manage a lot of the population in a value-based world.
Well, and what's interesting to me when I speak to policymakers and sort of pundits about telehealth tectonic plates is they talk about the need to capitate and they talk about how it will be audited and the challenges of doing that. And to me, telehealth is the mother of auditable technology and transaction encounters. And you can take it a step further. It's also an incredibly powerful population health management tool. Because if you can overcome some of the privacy considerations, you can have a fully transcribed encounter that's also prompted by evidence-based medicine workflow tools for that provider. to make the best practice of medicine. And then you can use that to actually trigger the best possible follow-up for that patient and probably improve outcomes over time. Maybe not within the actuarial 12 months that most payers are interested in, but certainly you have a lot of opportunity to pick up addressable, preventable health issues in that interaction.
It's interesting. We had a nice question come in that I think is on point. We'll have time at the end for Q&A, but I thought it was relevant now. I mean, we talked a lot about the financial incentives, aligning the financial incentives. That's clearly important. But a question came in around the consumer's perspective and perceptions around quality and how that impacts utilization. At the end of the day, right, we've opened the door. Consumers will walk through if they feel safe and secure. And I guess the question was, what are our thoughts around those consumer perspectives?
Yeah, I did not write the question, but I would have if someone hadn't, because I don't think all the telehealth is created equal, right? So, we've got people used to, through great companies like Teladoc, to have these really transactional relationships through telemedicine. I'm sure there's a lot of people who are listening to this who have tried it for a sore throat or a stuffy nose or a fever. And now we're really transitioned as a result of COVID. We actually did it before, but now people are seeing sustained relationships that are virtual first. So these are not ones where you just pop in and out and it's convenience, although those are there. This is about a sustained relationship. And this is our moment. Like, if these sustained primary care relationships don't work the way that we hope, and these are really ones where you're not just reacting to a need at the moment, you're actually holistically taking care of that patient base. Usually in a different fee structure than a fee for service. It's a per member per month on behalf of an employer, on behalf of a payer, but really going to where the patient wants to be. The other thing I'll say is I think there's going to be a real difference in different specialties. So I hope with everything I have that mental health, for example, will forever be changed from an access standpoint because of people's ability to now know that visits online can go very well. Maternity, to the chronic, I think Steve brought it up and Nina brought it up. Chronic care management, I think, will forever be changed because we cannot bring patients in who have a chronic condition in for routine visits. It'll be too dangerous to have them come out and not efficient or effective. Maternity care, forever changed. We are not going to have prenatal visits in person at the level that we do. So all of these things will be right. The virtualization of them has to be done really well. It's not just opening a visit on Skype. It is a holistic approach to those states. Condition.
Some of it is really too soon to tell, because I think what we've seen with COVID is a tremendous amount of physicians adopting telehealth to replace the lost revenue or lost encounter of their panel of patients because of the inability to serve in-person visits. So the number of physician friends that I've counseled through of which platform to adopt and how to onboard and how to think about reconciling that into revenue cycle management so they get paid for it. And then them coming back and saying, hey, this is actually really great. I can do this any time of day. It works just as well as a real encounter. And I can do it in my t-shirt and my jeans instead of in the office in my white coat. So that's very different than outsourcing to a Teladoc or to a Gluco or Livongo for a specialty care where the entire patient encounter begins virtual and stays virtual. And I think it's been a great catalyst because consumers and providers have now experienced that this can be a great way to deliver care. But the question will be when you return to the ability to do in person, how much will resonate. One thing that I think the loss of revenue for a lot of primary care and small specialty practices will be irrecoverable. There'll be a lot of practices that are insolvent and that will either close or they'll be acquired and consolidated. That will lead to less consumer and patient choice or access. And then there may be a new world in which your alternative will be, lesser access or only your telehealth encounter for primary care provided through your employer.
Yeah, I think the quality question is a great one. And my personal opinion is this is a lot like, software as a service where there were horizontal platforms like SAP and Oracle, and then you had vertical solutions for each specialty area. We have companies in plumbing and construction, or take the EHRs. You had you know, Epic and Cerner and Allscripts, and they were really horizontal solutions, you know, and then you had vertical software companies come out like WebPT and DocuTap, which is in the urgent care, and you had behavioral health focused companies. And I think with telemedicine, it's the same thing. You're going to have primary care chassis, basically, that do urgent care, primary care like things. And I don't mean to put Teladoc in a bucket because they've also expanded behavioral, to Nancy's point, but you're going to have these platforms, and then you're going to have vertical specialty areas, which are really go deep in a specific area. So, you know, Livongo is a great example. We have a company called Hinge Health. We just seeded a company called Folks Health, which is focused on the queer community, LGBTQ care, which is very, very specialized. And so and Nancy's got a company called Cricket, which is focused on the renal space. And if you talk to those teams, the depth and of the teams, their knowledge of those industries, I mean, to be a specialist in nephrology is so different than being a primary care doc. The workflows, the standards, the regulatory issues you have to think about, the patient and their experience, the holistic nature, it's just so different that what I think you're going to see is a verticalization of these full stack, you know, specialty management powered by telehealth, remote monitoring. And that's where I get comfort about the quality, because those teams are thinking so deeply, like Hinges in musculoskeletal care, like they're thinking, you know, so deeply. I know Nancy's company Cricket, so deeply in nephrology, and that's where the quality comes in, because they almost look like outsourced practices that are doing chronic care remotely. And that's where I feel good about the quality, is you got really strong experts thinking deeply about this and utilizing technology to power their platforms.
Yeah, so I tell you, this platform is incredible here. The Q&A, an insatiable appetite. The number of questions coming through is insurmountable. But so yes or no, this was an interesting question. I think it's right on point. Yes or no, can the payers drive a different behavior through the utilization of telemedicine by stepping up reimbursement for certain therapeutic classes? Can they drive the ultimate utilization?
Well, I'll step in here. I think our experience, because we have quite a few of our companies are payer facing, meaning payers are looking for alternative models to offer to their members to solve problems. Steve mentioned Cricket on the renal side, Maven on the women's health side. There's many, many examples. And they're doing that because they feel as though they're more holistic solutions. They're focused only on those specialties, the depth of how do you engage a patient, what keeps you from being successful with the patient, how do you drive the quality, how do you keep the unit costs down, in a way that they really are not getting from just the traditional healthcare systems. And many of these are working in collaboration with the healthcare systems. So absolutely, they can contract for it, they can shine a light on it, and they can obviously reimburse for it.
Yeah, how about you, Steve?
We see it on both sides. We see it both in constricting and expanding. So we have a company, Genome Medical, that's really a telehealth for medical genetics and genetic counselors. And their payers are interested in the responsible use of genetic testing and not having it be used more broadly than is appropriate. So they drive steerage through a rented telehealth workforce of specialists that may exceed what's available in the local, hospital community. So they're kind of tightening the network by driving it through telehealth and experts. And then on the other hand, we have another company, Papa Pals, which is an MA-sponsored solution to address loneliness in seniors. And this was an in-person service where college students were being paired with seniors who were suffering from loneliness and isolation to do non-clinical care, help with errands and play card games and the like. They pivoted very quickly to all telehealth during the COVID epidemic. And the payers have been actually really expansive in promoting and pushing that because they recognize that there's both a brand halo, but also a real benefit for outcomes in solving for loneliness, isolation, and depression.
Yeah, I'd say in healthcare, you're never going to go wrong by following the money. And look at the top of the stack of the money, it's the payers. And in truth, I gotta say that the insurance companies, for the most part, in their MA book and other books, want to drive to value-based. Why would they not? Why do they want to do that? Because they can keep 15% of the premium, and they can push the risk down to the provider, and they don't have to do all the stuff to medical management. And so their incentives are to do that. Where I actually think the problem is in the system is the employers. And by the way, the employers are actually payers, right? Because they're large, self-insured entities for the most part that pay for care themselves. And guess what? Our employer system is still in this world where, and I get it because you got to fight for talent, and maybe COVID will change that a little bit, but you know, you still want to offer gold-plated plans, wide PPOs, broad, you know, really, you can go see any doc at any time. That's kind of the antithesis of value-based care. Like, that's where those two things meet. And so I think the employers actually could put, and have been slow to actually adopt value-based care movement. If you talk to any payer, like, their commercial book just doesn't, very rare, like Blue Cross Blue Shield North Carolina is pushing a little bit, but very rarely are payers commercial you know, books like asking for a value-based solution, and they're a large part of the payment ecosystem. So if I were to point at anybody, it'd be like, you know what, get the large self-insured employers to realize that the gig is up. In order to drive down costs, there's only two ways: bring the consumer into the healthcare ecosystem, because the consumer always shops on price, you know, based on, you know, equivalent value, and change our incentive system. And I think the ones that are holding us back from a value-based system are actually the self-insured employers, unfortunately. And you know, we'll see if that changes.
Can I be optimistic for a second?
Go ahead, Nancy.
Sorry. I was just going to say that, yes, so employers are a critical part of everything that we do, but let's just talk about post-COVID. They have had to get a little more involved in the health of their employees than they had before. You know, they have to think about the environment. So we're seeing through companies, our company Firefly and others, doing these return to work programs where they're literally hiring us to surround their employees, to make them, to test them, to be there, to give them, to have virtual visits, to deal with the mental health issues, to review. So I see this level of attention to the employees that we haven't seen before. And then on top of that, we're saying, don't you want to promote virtual care? Or don't you want to say to your employees, we have a benefit that will actually help you get access to care without putting you in harm's way? So we have seen, I'll just give them a little, I'm going to stay optimistic here on this, hoping maybe that this has given them a different point of view.
Yeah.
As another data point to that, the Pacific Business Group on Health that aggregates the major HR and benefit decision makers, large employers in the Pacific Northwest, through their initiatives, they've seen a 2,500% increase in telehealth for behavioral health by employers advocating and advertising those services during COVID. So I think there are initiatives. But I think, to Steve's point, you know, employers could have more marketplace purchasing power than they exert or have exerted to date. And it'll be interesting to see. We know there's going to be a massive decrease in healthcare utilization going through 2021. There's no way all of these elective procedures that have been deferred are going to come back apace. And so employers and payers will see a lot less utilization. But because of provider consolidation that I expect to see, I think prices may still go up. So it'll be interesting to see whether next year there will be a tussle between employers pushing back on increased premiums, even though their actual population utilization will have been much lower at a time where they're also having lower employee ranks potentially. So it maybe, Steve, it'll be your time when the employers do flex their muscle and push back and say, we need some, you know, capitation, population health management. We need to see a different outcome for our dollar spent. And certainly in our portfolio with companies like Truveris, which it does formulary analysis or business intelligence around the pharmacy benefit. And Nancy, I know you have significant investments in this area too. There's a lot of appetite, even as busy as employers are right now, there's a lot of appetite to take a look at where they're spending money and where their drug spend actuals versus expected are. So I think there will be some tightening of the belts.
Steve, any you wanted to chime in there?
I'm good. Thank
You're
you.
Good. So you know, this format really is incredible. The questions keep flying in. They generally fall into the following categories: consumer, quality, reimbursement, regulatory, and one I think that, you know, Nina, you and I chatted when we prepared for this, and that's social determinants of health. I think we've covered a number of them, but I guess the question, because the theme of the question is, you know, what's the impact of social determinants of health? I mean, it's great if you have a computer at home. You know, it's great if you have access. You know, will telemedicine create a different access barrier to healthcare than currently exists?
Well, we're certainly seeing this through the lens of PAPA, where we have seniors with chronic health conditions, particularly low-income minority seniors and dual eligibles, that really should be going for in-person visits to manage their chronic health, that are terrified to do so. And they are not going to be completely served by a virtual visit. I've also, can share anecdotally from the CEO of Iora Health, which is a well-known Medicare Advantage sort of comprehensive care service in the Boston area that Nancy and Steve know well, that they're struggling to get some of their vulnerable panel members in for much needed care because there's so much fear about COVID. Also, as it relates to, vulnerable populations in terms of kids with behavioral health issues in low-income circumstances that typically would access services through the public school system, which can do quite a good job, not nearly enough, but providing services. When school is not in session, those services are very difficult to render. So those are things that we're thinking quite a bit about. If this is going to be a longer-term shift, how do those folks not get left behind for lack of either infrastructure, power, strong, internet access, or just comfort with establishing relationships or trust in a virtual setting in conditions or areas that may be historically already stigmatized.
Yeah, no question. I think, education will play a big part in that as well. Nancy, go ahead.
Yeah, so this has been an area of focus for us for the last couple of years, social determinants of health, and it's been interesting to watch. We have an investment in a company called Unite Us, based in New York, and it's serving communities across the country. And it is I think it represents about 220 different types of social determinants: housing, mental health, food, transportation, so on and so forth. And this has been something that's been acquired in the past by states to support all of the government lives. It's connecting supply and demand. So it allows someone to put an order in for one of these things and they fulfill it, and it has a care coordination platform. Well, since COVID, there has been, not for all 220 items, but there has been a sort of emergency COVID version of this that is being deployed by states. So this is a very interesting thing, that we went from predominantly Medicaid needs and really fulfilling those gaps to a general need by even just people with chronic conditions who can't get out and get food. So we've got a lot of inbound interest, which is great that we can help solve it. We would prefer if there hadn't been a pandemic and an expansion of this, but all of a sudden there's a laser focus on going back to chronics, in addition to the traditional populations that needed gap closure with social determinants, which is how do you keep people home and safe, and how do you get food to them? How do you make sure, again, that they're connected to the right telemedicine, or they're connected to mental health services? So having a platform that's almost like a utility, the way Unite Us has been very helpful. But this is just a growing need, and more and more work being done about the correlation between that and medical spend and quality of care.
Great. Thank you, Nancy. If I could, let's pivot to the future a bit, right? I mean, I think you're all investors on the panel. Has COVID-19 kind of colored your thinking on how to invest, what to invest, how to assess investments, due diligence relating to those potential investments? How has it kind of colored your thinking on those attributes?
I mean, I'd say for us, our North Stars are still, they were true pre-COVID and they're true post-COVID. I mean, we really have 3 North Stars in our practice. Sort of one is that, this is an industry that is way behind in terms of adopting technology and automation. As I said, probably 20 years. And I think that's going to continue to persist in terms of the evolution of the industry. And, it's like, if you could have invested $1,000 or $1 in, Salesforce 20 years ago, we would all be smart, retired people at this point, and I think that's kind of where we are in healthcare. Like, we're at that moment. And I think COVID's only, obviously, for what we talked about, has has sped that process up. The second North Star for us is that we believe the consumer deserves and needs to be more involved in their care. And frankly, I would say up until 5 years ago, really wasn't for a lot of the reasons we talked about today. And I think that's going to change. It has to change if we're going to drive down the cost. It's the only thing that's worked in almost every industry is getting the consumer involved. And then the third North Star is I do believe the other lever, if we're going to drive down this unsustainable growth in healthcare expenditures versus GDP, is that you're going to have to change the incentive system. And I think that's probably the slowest. Honestly, pre-COVID, I would have said the consumer is really hard, just like we talked about pushing the consumer to use telemedicine. I think that's changed. I hope that's changed. The fee for value, it's very unclear where we stand. In truth, I think this will the first and last time you'll ever hear me say this, Steve Krause. I think I give credit to the Trump administration. They've actually done a good job on this front. I was worried when the transition administrations happened that the fee for value movement would fall at the wayside. It almost did with Tom Price and getting rid of bundles. But to the Trump administration's credit, they've really pushed, and they've actually pushed pretty aggressively on a number of fee for value initiatives. Which if you're going to change the cost curve, I think you have to change the incentives here. And so, that to me is more of a 10 to 20 year roadmap. I don't think we're going to get there tomorrow. But I think that's a place where we're investing. So our core tenets haven't really changed. Now we can talk later on about how venture capitalists figure out how to do deals and how, by the way, it's not just venture capitalists, it's also entrepreneurs. Like, how does an entrepreneur figure out that whether they want to work with me or Nancy or Nina or all of us in a syndicate? Like, it's really hard on the entrepreneurial side. And frankly, they're making as big of a bet on us because they're, we have a portfolio. They have one board, they have one set of investors. So I actually think it's a lot harder for an entrepreneur in these times, unfortunately, because that relationship, it's not just about the business and about the quality of your firm. It's also about the relationship. And it's just really hard to do by Zoom if you haven't met someone before. And so it's challenging.
Yeah. Yeah. But how about you, Nina? Any thoughts beyond those kind of core tenets?
No, I think those are incredibly good points. I mean, I would obviously add that we also have a very, very strong North Star towards scientific innovation leading to better platforms and therapeutics and how we understand, detect, and treat human disease, and that being a part of the solution as well. I would say, one of the things I think I am thinking about is as a result of this strange time that we're in is where we build companies. I think there is a very, very special synergy, especially at the early stages of a company, about being under one roof. But we have been for some time because of the talent grant and the cost of doing business and sort of the scarcity of experienced executives, we have been building companies a bit more virtually with a somewhat more distributed team. And during the shelter in place, it's really leveled the playing field because everyone's been distributed and there hasn't been the asymmetry of culture. And that's opened up some thought process about whether you can build companies that are a bit more distributed going forward to take advantage of lower costs of doing business in terms of real estate and labor costs in the various core areas that we've been building. So that's a thought process that I have. It's just sort of business thought versus business model.
How about Nancy? How about you?
Yeah, I mean, I obviously agree with when you have those true North Stars. So when we work on cost and quality, we work on undeniable problems. They're undeniable problems. Trying to figure out a better way to deliver kidney care, a better way to serve women's health. We have a company that focuses on opioid addiction and pain management. All of those things are still there. And then there's absolutely no doubt we have to think about who buyers are, how distracted they may be. Or is this a priority? Chances are, if it wasn't a priority before, if it wasn't a priority, the things that were priorities before, high priorities, are still high priorities. Some of the new things that are coming in are all around efficiency. So every single time I'm on the phone with a provider, they're talking about efficiency. We need something that's going to actually move the needle now on our costs, because we've got some real problems in terms of our So that's absolutely true. And then it's not really the question you asked, but I think we're all in this for the companies that are who have always been in the space of virtual care, virtual first, or social determinants. It's really about how to double down, how to get them to grow as fast as they can, support them in any possible way. And we've had tremendous, to Nina's point, we've had tremendous innovations. Like I'm bursting with pride over what some of our companies have done around going completely virtual implementations. And I'm like, what are we giving up? They're like, nothing. I'm like, good to know. Glad we figured that out, that we could do things. So there's so much innovation going inside of all companies that is going to help us scale and get these solutions solved more broadly.
Yeah.
And for sure, there's some companies that will not be able to sell during this time or not be able to sell well. And and this is perhaps more in the portfolio rather than new investments. So we're really having very thoughtful conversations with management teams about where do you pull back on go-to-market and commercial and really invest in your own internal efficiencies and automation, strengthening platforms, strengthening security architecture for growth so that you can have better implementation when some of this distraction and some of this tension is gone. If you believe that fundamentally you have a really good product market fit, you just need a couple quarters until the market's ready to come back and meet you halfway.
Yeah. You know, there's such an interesting question came in, I guess, through the lens of a potential company or an emerging company. In this virtual world, is there a bias towards, working with either organizations or people that are known entities as opposed to, meeting, new people for the first time? And is that a challenge to you as an investor, or does that result in any bias to those who can't sit around a table and can't kind of see them face to face? I thought that was a very interesting question through the lens of a potential investee. Any thoughts on that?
I'll start with yeah, this has come up before, in some of these panels. First of all, I think, every single day, and I'm sure Nina and Steve will say the same thing, I probably meet 2 new entrepreneurs a day virtually. And actually now it's the norm to get onto a Zoom conference, which was not the norm before. It was mostly telephone calls, I think, at least for me. And honestly, I feel sometimes you get even a better feel for the person. What's the circumstance, what's their reaction when their kid walks in or the dog starts barking or whatever may happen. I think it's a fine way to start a relationship. And we do have to think about what happens. And I think we've all talked about this offline as, could you imagine 2 things? Could you imagine hiring someone you've never met in person? Could you imagine investing in a company that you haven't been on premise? And I have to say that at least for me personally, I can get a lot out of a Zoom conference and out of, discussions over time. And about the only thing I feel that's really missing is you don't get the feel for the office, the quote unquote office. What's the buzz? What does the culture feel like? What are the artifacts that you see in the office? There's some things that can't be replicated, but at least in my opinion, we can get pretty far in building relationships this way.
Yeah, I mean, I think, listen, this is a really hard thing in this world. We're all trying to figure it out. But certain things are true about what we look for. And I think it's probably true for Nancy and Nina. There has to be a fit in sort of the thesis, right? Or the belief. We get to make a few investments a year, and generally they tend to be what I call roadmap driven. Nancy has probably certain areas she's looking at, Nina does, and so do I, right? And so I would encourage entrepreneurs to really figure out whether because if the VC has a thesis and a belief that something should exist out there to solve one of those undeniable problems that Nancy said, there's going to be a more high likelihood that there's going to be synergy between what you're doing and what they're interested in. So I'd really test that as an entrepreneur. And you can do that. Someone could ask me to talk about certain things, and I could talk about them well, and I can talk about a lot of things not well. And you can figure that out as an entrepreneur. So I think that should be a criteria that you test. I'd say, so that sort of fit and thesis, clearly if your business is doing great and you got great metrics, I mean, that's going to really help. It's harder if you're an early stage business, but the way that you so metrics obviously matter, right? That mattered in the old world, it matters in the new world. So the more you can talk about the metrics, whether they're actually existing metrics or the way you think the business is going to play out, that helps obviously. And that could be communicated virtually. I think the final thing is sort of, is there a fit with the entrepreneur? And what I look for is people who are super passionate energy and just want to solve this problem. And I was just talking to someone yesterday, literally in the behavioral health space. I'd never met him. He was based in New York. I mean, this guy's energy for what he was doing, just almost like reached through the Zoom camera and pulled me in, right? I mean, it just was like, holy cow, and he's all over the metrics, and it's still an early stage business. This is a, you know, early Series A deal, right? And there was a fit for the thesis that I was looking for. So yes, I think you can do it. The hardest part that I haven't yet had to do, because I've done 2 seed deals and I knew both entrepreneurs before in the COVID times, is there is something to like being able to go for a walk or have a lunch or a breakfast or a dinner. There's something to that that's like taking it outside of the business context, the things I just talked about it, and taking it into the personal context and really making sure that that fit, that marriage that I talked about is going to work. Because it's not just about the metrics and the energy and the thesis and fit. It's also about like, are these 2 people going to work together for, you know, 10 years, right? And that's almost the most important thing. And that's harder to figure out in Zoom, honestly. And I've been sort of thinking about how I might do that when I get to that point. And that's the one I don't have the answer to yet, to be honest.
So interesting question just came in, and Nina, I'm going to direct this to you if it's okay, but with on the biopharma and biotech side, with so much focus on, you know, a vaccine, you know, is anyone focused on anything else? And what are those therapies? What are the things that you're seeing, you know, getting funded, you know, during this, you know, unprecedented time where most folks think, you know, the vaccine is the only thing that's on pharma's attention?
I think there's a huge amount of lay press attention and sort of generalist investor attention on Gilead and Moderna and Novavax vaccine. And that's why we've seen this incredible capital market, you know, public market cash inflows into the biotech sector. But on the private early stage investment, you know, that's the distinct minority of what we're seeing. A lot of
I think Nina might have frozen.
Yeah, I think Nina might have frozen. Our first technical difficulty. Good thing we have another question in
part of the COVID era.
In the line, right? So I'm gonna, while we wait for Nina and that to get fixed, I'm gonna pivot to an interesting question came up around the focus on remote monitoring, contact tracing, right? And I guess one of the questions that came in, there was a real concern on, you know, can an emerging growth company really compete with big tech and the non-traditional market participants who seem to be aggressively, you know, getting into the space? Steve, your thoughts on that?
That was really clever of me.
Sorry, what?
That was really clever of me.
You want to finish your thought, Nina?
Yeah, go ahead, Nina.
I was just saying that I think most of the private investing attention is actually on what we were focused on prior to this pandemic, which is oncology and autoimmunity and rare disease and a real resurgent attention to CNS disease. I think far more suffering, death, and economic damage will come from Alzheimer's than will come from COVID, even as devastating as this is. But certainly the companies in the private stage are looking for, if they have science or technology that can be helpful, can they repurpose? Some opportunistically looking for, can they use it as a hook to raise money? But really our thrust and venture strategy is decidedly non-COVID, much as we are very, very invested, like the rest of the globe, being a great impact.
And do you see those deals getting funded during these times?
Other therapeutic deals getting funded? Absolutely. Absolutely.
I mean, the biotech markets have done great. You know, there's been probably 6 or so IPOs. They've all traded up in a post offering. They've held up. The markets are going strong. And, you know, like to Nina's point, these are, you know, to use Nancy's, these are undeniable, unsurmountable, huge opportunities where there's just so much more innovation. Talk about 10 years ago versus now in the biotech world. It's amazing how far the fundamental platform technologies that are used by scientists to discover new therapies, new targets. It's impressive. The other thing I'd say about biotech is it has a little bit of advantage. I talked about metrics that we look for in healthcare, IT, and services companies, and not to disparage biotech. There are a ton of scientific and clinical metrics, but these companies are often funded for 2 to 3 years, right? Even when they go public, you know, they have a P&L in their filing, but there's actually no P, right? And there's only an L. And so they aren't necessarily held to the quarter to quarter demands, that are placed per se on companies that have revenue metrics and EPS metrics they have to hit. I think biotech investors tend to think much longer term because they're used to the long-term nature of the business. And so if you can fund a company for 2 to 3 years, I think the thesis is, that company is going to be able to weather COVID. Hopefully there's a vaccine, as Nina said, by that time. And the fundamental opportunities and market sizes and need is tremendous. So I think it's just a different financing strategy, a different way that investors, both private and public, look at the companies. And so I actually think the biotech deals have gotten done even at a sort of, a normal pace in this environment. The hardest thing is for the operations of the labs. Those have slowed down because of social distancing and needing to be careful about the people who work at those labs. So some of the clinical trial timelines will get slower, but I think the overall opportunity hasn't really been changed by COVID in some of the disease areas that Nina's talked about.
Yeah, yeah.
We're in a public bull market right now that's lifted by hope and speculation and in the vaccines, and that will correct, but that does not mean that the fundamentals underlying a really strong thesis to be long-term bullish on biotech are in any way changed. It's an incredible sector with a renaissance unlike any we've had before.
Got it. How about you, Nancy? Anything you'd like to add there? Or?
No, you have the two experts. I'll leave it.
Great.
On the biotech side.
So Nina, when you zoomed out there for a bit, one of the questions that came in that was super interesting was, the focus now on contact tracing and the like. Big push by what I'll call big tech to enter that market. The question really was, is there an opportunity for an emerging growth company to enter that space, or do you think that that'll get absorbed very quickly in the next 30 days, 60 days, 90 days by large existing technology companies and perhaps even consultants?
I have a personal opinion about this that's just a sort of more from my public health background and my citizen background than it is really from the technology. I think if you had time to make a purpose-built application for doing really good sort of CRM and workflows for contact tracing and to really integrate all of the resourcing with what next, someone tests positive, who to contact, how to tie them into testing and social isolation and quarantining services, or availability of a motel room if they need it, or healthcare if they need it, and how to feed that into centralized databases. One could do better than what exists both in the global public health contact tracing world of small, bespoke, purpose-built, not-for-profit software, and what exists in the large, Oracle, Salesforce, Microsofts of the world today. But I think we have a need with such incredible urgency that is scalable and secure and has been utilized across millions and millions, if not billions, of transactions and data points of different types of information and multi-user and cloud enabled, that I would encourage the citizenry and municipalities not to mess around with startups and instead go with contracts to the big guys who have done that, and encourage the big guys not to price gouge and be opportunists, but rather to do it almost as a pro bono, because the public health need for speed and reliability is there. And then as it relates to the Bluetooth and tracing technology on smartphones, I think that's something that I think is sort of fundamentally un-American. People may opt in, but I don't think we're going to see that come to be in a way that's embedded in phones and default opt-in. I just don't think we would sign up for that as a populace.
Yeah. How about you, Steve? I know we were about to venture into that previously.
I mean, I just think, I have to say, it's sort of imagine if we had a truly interoperable, data system and we had made investments in public health, where we'd be. So I tend to agree with Nina. It's this is another good thing that the administration has done, is their new interoperability standards, that came out. By the way, no one paid attention to them because they came out right during COVID. But I actually think if you think about the sort of first North Star I talked about, the digitization of care, the EMR market's sort of we're done, right? That's now a replacement market, not a greenfield market. And frankly, a lot of the investments in that space, I was wondering whether there was going to be a lot of opportunity. But I think the interoperability standards that have been passed are huge for our industry, because they take what is a very siloed set of constituents who consume data, frankly, vendors who want to be closed systems for the most part, save for Nancy's old company, Athena, who was trying to push on that and was working on it and still working on it. But most of them want to be closed. And, you know, in order for the technology that you talked about, Pete, or that Nina was talking about to actually exist, you actually have to be able to share data. And our system is not even close to doing that. Like, we have a closed infrastructure. Most of the rest of the American economy that has software is open. You have APIs, you have lots of different standards. There's plenty of developer-led companies that are now public and billion-dollar companies that have been built. We don't have any of those in healthcare. So I just don't think we have the infrastructure that we need to be able to do remote contact tracing in the way we need to do it right now. We should have been making those investments 5 years ago and also investing in the public health infrastructure. And so I think we're going to default, because we can't waste time on this, we're going to default to the sort of, you know, partners in health model of just getting feet on the street and doing it the old fashioned way, which frankly is sort of, you know, a theme here, right? Healthcare goes back to the services business. And so I think that's the best, we got to be right about this, and that's what we can do now. But I wish we had made these interoperability standards 5-10 years ago, because I think we'd be a lot farther down the path. But I'm excited about the future because I've seen so many other parts of the economy take advantage in software with open systems and data sharing. So that's a real opportunity for us moving forward.
Yeah, yeah. No, this has been incredible. We have about 5 minutes left. We have over 150 questions, believe it or not. I've tried to categorize them. They generally
some pizza. Where's everyone going?
They generally
just keep on talking. I mean, we're good at that, right?
We're in the way of cocktails. That's what I.
So one last point that we could head to the cocktails, because we really haven't touched the regulatory front a little bit. You know, your one wish list for the regulatory environment to really accelerate the future of health, and then you know some closing remarks from each of you.
I guess the easy layup one is just that we continue to remove the regulatory barriers around telehealth. I'd hate to see that go back to the way that it was, because I would know the reason for that, which would be significant lobbying efforts by certain companies who profit from it now. So that would be my one.
Mine be, we talked about vulnerable populations. I think, you know, just a greater investment in Medicaid. We have so many people. It's frankly been an area that has been so underinvested. We've talked about companies that are focused in that area, and frankly, moving that system to a value-based system, because I think there you will be much more proactive. You'll manage things ahead of time. We talked about nephrology. Instead of dealing with folks when they crash in the hospital and need end-stage renal, you know, have end-stage renal disease and need dialysis, you'll actually manage them earlier. But there's so many examples of this, right? You know, I think a value-based system will incent folks to invest in preventative, primary-based care. And I think, frankly, the Medicaid population deserves it the most. And so I think a real focus there and investment there would go a long way to help our system.
Got it. How about you, Nina?
I'll keep escalating up to the unicorn wish list if we're dreaming big here, and to take it from Steve's sort of vulnerable Medicaid expansion. I think to ensure safety net and access and rural and community antitrust supervision, make sure that consolidation on the provider side doesn't lead to the abandonment of access in those vulnerable populations. And with that might also come some greater scrutiny or maybe changes to the definition or the not-for-profit status of some provider systems.
Yeah, great. Well, we're coming to the top of the hour. This has been an incredible experience. I actually really enjoy this format. There's not for a lack of content or, you know, just emotional just involvement in this process. I want to thank all the panelists. You know, such a treat to see each of you again. I'm glad you're all healthy. I know Jody had some parting thoughts and our entertainment, you know, after this process. But I do want to thank each of you for attending this and your continued commitment to, you know, our perspectives around the future of health.
Thank you, Peter. You've been a terrific moderator.
Thank you.
And I hope we all get to continue to take advantage of the silver lining, which is all the opportunity that's been put in front of us.
Yeah, I hope so too. I hope we don't go backwards and just, you know, try to get back to normal when we you know, can really advance, you know, everything that we've been talking about collectively, right, for about 10 years. So So Nancy or Jody, what's on the agenda for our cocktail reception?
Well, we'd like to thank you all for joining us, and now I'm going to throw it over to Natasha and Rich, who are here to show us a couple of refreshing cocktail and mocktail recipes. Thank you, guys.
Yeah, thanks so much. It's good to be
Hi,
here.
everyone. My name is Natasha Soto-Albors, and I'm a mixologist based in New York City, most recently at Motel Morris Restaurant, which is located in Chelsea.
And I am Rich Dreyer, and most recently sommelier at Blue Hill at Stone Barns in Pocantico Hills, New York, just up the Hudson Valley a bit from the city. And we are husband and wife.
Yes, a married couple, and we've been quarantining together. And what's been wonderful about our profession is that, you know, in this time when so much is changing and people aren't able to be in restaurants or bars in many places, we've been able to share our knowledge and sort of bring the home bar to life and make your cocktails at home a little more elevated, more sophisticated. So we have two drinks that we're going to share with you today. One is called the Deloitte Daiquiri, and the other is the Deloitte Desjardins. So one is a zero-proof cocktail. That's the Desjardins that Rich will be showing you. But I'm going to start us off with a daiquiri today. And I think what's wonderful about daiquiris is they get a little bit of a bad name sometimes. We think of a frozen daiquiri that maybe we'd find on a cruise ship. Perhaps not the best quality of cocktail, a little bit diluted, almost like a slushie. But a true daiquiri is a very classic cocktail. And it's one of those cocktails that when we're learning to bartend, we make that so that we learn how to then play with all of those elements and then create our own variations. At its heart, a daiquiri, a margarita, and a gimlet are actually very similar drinks. They're all based on the proportion of balance, right? So we're always trying to balance in our cocktails, sweetness, acid, and then of course the flavors of the spirit itself. So in a daiquiri, we're using white rum. And today I chose to use Don Q rum, which is from Puerto Rico. My family's from Puerto Rico, so I am partial to Puerto Rican rums, but you can certainly use any white rum that you prefer. We just find this one has a really great clean flavor and works super well for this particular drink. And yes, Rich.
No, amen.
And then I'm also using an aperitivo from Fort Haves Spirits. This is not something you'll find in a traditional daiquiri, but I am featuring it in this cocktail to give it a little spin, a little bitterness, and something a little bit unique. So Fort Haves Spirits, based in Brooklyn, and they focus on making Italian-style spirits. They make beautiful Amaros, and they also make this aperitivo that's in the vein of an Aperol or Campari. So if that's something you have on your bar, you could certainly substitute it. You don't necessarily have to use this, but I do highly recommend it. The other element for our daiquiri that we are making specifically for the drink is a rosemary mint simple syrup. So I know sometimes making syrups at home can feel a little intimidating, like it's a lot of prep work, but we're here to encourage you that it really is not that difficult. And what's wonderful about making a syrup is that you can store it in your fridge from anywhere from 4 to 6 weeks, and it will hold up. Those flavors will still be beautiful, and you can use it in a lot of different drinks. So anytime we make a simple syrup, we're starting with equal parts water and equal parts sugar. Essentially, we put that on high heat. We bring it to a boil until the sugar dissolves completely. Once that's happened, you want to take it off the burner, take it off the heat, and throw in whatever you want to infuse that syrup with. So in this case, I did fresh rosemary and fresh mint. Rosemary has a really powerful flavor, so it will tend to overpower the mint if we did equal proportions. So I did a little less rosemary than mint. I would say about 5 sprigs of mint, 3 or 4 sprigs of rosemary. So you put that in the warm, simple syrup, and then you're gonna let it come to a cool, completely to kind of room temperature where you'd be ready to put it in your fridge. You'll wanna strain out the herbs using a mesh strainer, and then you can put it in an empty liquor bottle or a mason jar, and again, keep it in the fridge for over a month. So that's the syrup that I made to sort of give my daiquiri that extra little zing today. The other ingredients I'm using are fresh grapefruit juice and fresh lime juice. Grapefruit is one of my favorite citruses to put in a cocktail, and I think we often forget it because we think so much about lime and lemon. Very easy to juice grapefruit at home, and you get a lot of juice just from a couple pieces of fruit since they are quite large. So I've done that as well in advance. As far as my tools, I'm using a very simple metal cocktail shaker. If you don't have a cocktail shaker at home, a mason jar is a great hack that we have been telling people to use during quarantine.
As long as it has a lid.
As long as your mason jar has a lid so your ingredients don't go flying, that's an awesome substitute for a traditional shaker. And then of course you're gonna wanna have something to measure with. So I use a metal jigger. They come in different proportions. The one I'm using is 1 ounce on one side and 1/2 ounce on the other side. To expedite the process for our purposes today, I actually pre-measured out a lot of my ingredients just to make it a little easier. But again, whatever you are doing, it's always a good idea to measure because you want to make sure that you're being precise with your ingredients. I know we see bartenders, and some of us are guilty of it in bars when we've been doing it for a long time. We're pouring things and we're just kind of looking loosey-goosey with it. But obviously it's really important that the proportions are perfect. It's sort of like cooking in that way, or baking. It's important to be scientific about it. So the Deloitte daiquiri. So I'm starting with my white rum, and I'm going to do 2 ounces of that right into my shaker. And then the next element that I'm doing is that rosemary mint simple syrup. So again, I've already measured out, and I'm doing 3/4 of an ounce of that. That goes straight in. Then I'm using equal parts of my fresh lime and my fresh grapefruit. So my fresh lime juice is 1/2 ounce, and my fresh grapefruit is also 1/2 ounce. Those go straight in as well. And then the last very unique, not traditional daiquiri element is this aperitivo. Again, a bitter style spirit that is in the vein of your Campari or your Aperol. And I'm doing 1/2 ounce of that. So again, you can sort of see I'm balancing the flavors in terms of how much I'm putting in. I'm balancing out the citrus, which gives it the really refreshing tart quality, with a little sugar, a little bitter, and then of course the rum. And I'm gonna want to add ice to my shaker. Now, anytime you're shaking a cocktail, you want to shake it quite vigorously and for a long time. It's not just for show, it's so that we get proper dilution and that the drink gets really, really cold, right? So we're gonna go ahead and shake this. When your hand starts to feel almost like it's hurting, it's almost too cold to hold on to, that's actually when it's getting quite perfect. So that's good to go. My shaker has a strainer built in. Some of you might have this style at home, perfectly fine. But if you don't, you'll want to use a Hawthorne strainer, which is the bar strainer. You'll see it comes with a lot of bar kits if you buy a set of tools. And I'll just pop that right on top. And I'm using a coupe glass, which is sort of, some people think of it as an old-fashioned champagne glass or a Marie Antoinette era glass. Really beautiful for cocktails and quite popular in terms of the shape of glass right now. And I'm just gonna pour that right in. And you can see it has this gorgeous sort of peachy pink color, very, very summery. And then I'm going to garnish it actually with just a fresh rosemary sprig. So rosemary is really hardy. It holds up in the fridge really nicely, or if you grow it at home, it's something that you could pick from your garden or your patio in New York City. And so I just throw my rosemary right on top. And that's the Deloitte daiquiri. Cheers. So again, that's a really easy cocktail. If you're not a rum fan, you could do the exact same cocktail and you could sub in tequila. It would make it sort of a Paloma margarita feeling drink. If you're a gin fan, you could sub in a gin. And then you'd have something more in the vein of a really lovely summery gimlet. So what's cool about this is that flexibility again. Those 3 different spirits or vodka would also work, a little more neutral, but any of those would work beautifully in this and you'd have something quite tasty. So that's the daiquiri. I'm gonna let Rich show you our 0 proof cocktail.
Thank you, my love. Hello, everyone. So I decided to make the non-alcoholic or 0 proof cocktail this time around, and some people might think I drew the short straw in this case, but I actually really enjoy making mocktails. I think there's a trend now, or at least a real awareness of drinks not necessarily needing the alcohol, and these non-alcoholic or mocktails are not just for people who can't drink, but for those of us who choose not to indulge at the moment. And there are some products on the market now that make that really easy without substituting or having to replace the complexity. And one of those products I have right here, that is Seedlit. I have two of their products that I'm going to use in this drink. The first is called Seedlit Garden. That was one of the first that Ben Branson, who created this product in England, created. What he does is basically distill these different botanicals and herbs to give flavor to liquid, but they're completely non-alcoholic. He calls them distilled aromatic spirits, non-alcoholic. Then the second is Grove 42. This one, though, based on citrus. There are things like orange, lemongrass, ginger, all kinds of wonderful things that go into making that. So it has a lot of complexity and body. So you actually, if you do want to feel like you're drinking alcohol, but you don't want the effect, this is the perfect way to do it. Then I did another fun thing because I enjoy the combination of carrot and orange. I think it's a really beautiful flavor combination. I made something that is really popular down on the farm at Blue Hill where I work. And that's making different molasses, if that's a word, or sugars from different ingredients that you wouldn't necessarily think of as making sugar. One of those that I first came across was beet. Our chef de cuisine there, Bastien Guillauchon, he showed me how to make this beet sugar, which was basically just taking the juice of a beet and reducing it down to almost a syrupy consistency. And you can do the same thing with any root vegetable that has a high content of sugar, carrot being one of them. So you can see here this really thick, gorgeous carrot molasses that I've made. And that's a very, very simple process. It sounds complicated, but it's not. So if you have a juicer at home, you can just juice about 4 carrots and then take that juice and strain it through a fine mesh strainer into a pot and then boil that. Once it comes to a boil, reduce it to low, and then you just let it simmer until it becomes that syrupy consistency. It takes about a half hour to 45 minutes, but I think it's well worth it for that complexity in this non-alcoholic drink. Then the other thing I'm using, another ingredient that we love on the farm and we grow in the greenhouse, is turmeric. It's in that ginger family, and it has the same kind of properties that anti-inflammatory, but also that really spicy sort of flavor comes out. Though I find that turmeric is a little bit more earthy, if you can call it that. So what I'm going to do is first combine the turmeric in my mixing glass and a little bit of that same rosemary and mint simple syrup. And then I'm going to muddle it. Muddling is a technique we use to extract flavors from things that wouldn't necessarily show themselves right off, like the juice of the turmeric is inside. I could juice that, but I really like getting some of the skin and some of the other oils that are and nutrients that are in the skin into the flavor of this drink. And then you can also do the same thing with mint, like when you're making a mojito. It breaks up those oils, it gets it really incorporated into the drink. So I'm just gonna muddle that really quick. And the best way I know is to place your muddler right on top, press down and twist. That starts to release all the juices, and you'll see it starts to become almost like a baby food consistency. And we don't need to do it too hard or for too long before it's really good and extracted. So you can see there, it's that really nice kind of juiciness starting to happen. Then I want to add my carrot puree or my molasses here. And this is about 3/4 of an ounce of that. And then on top of that, I'm going to add my seedlit. So first, I want that orange flavor. And here I'm using the Seedlit Grove. This is going to be the majority of the liquid we use. So we're going to use 1 ounce of that right into the drink. Then the Seedlit Garden, because I want to pull out some of those gardeny, earthier flavors in the carrot using this seedlit, and I'm going to use about 1/2 ounce of that. And then to pull those things together, I want a little bit of citrus. I want something fuzzy and something a little bit sharp. So I'm using lime juice. You can also use lemon, but that's going to give you a little bit more garden flavor. And then this is about 1/2 ounce as well. So notice I haven't used too many ingredients to make this drink. A lot of the sugar is already there in the carrot, which I really love. So I only had to use about 1/4 ounce of that simple syrup. And then next we just add our ice. And then I'm going to use this 1/2 tin with my mixing glass just because I like to see what's going on. Looks pretty good. Break the seal. And then this is going to have a lot of color. You'll see the carrot really, really gives it that beautiful, vibrant orange. So be careful where you put it. And then I want to take a highball glass. That's a cylindrical glass that you would serve a Collins in. I'm putting a little bit of regular ice in the bottom and then some circular ice that sort of shapes to the glass. And then with my Hawthorne strainer, as well as a fine mesh strainer, pour that right over the top. And you can see that gorgeous color already. This is just to make sure that none of those bits of turmeric get in there that can make it kind of unappealing to chew on. Turmeric has a lot of flavor and can be really overpowering. Boom, gorgeous. So then, to finish it all off, this is just club soda, plain. If you have a hankering for some other flavor, lime, lemon, go for it. Even grapefruit will do very, very well in this. And we're just gonna pour that straight up to the top. And then I like to do something that's in the drink to garnish. You could use mint sprigs. I've also made a little carrot curl right here. This is very simple. You just shave the carrot down to the middle with your peeler and then add that on top. I like mint and rosemary because they're also in the drink. And one of my favorite little tricks I like is to smack the glass with it. It releases the oils, you can smell them, and it stays on the glass that way. So you're having an aromatic experience as well as that experience on the palate when you finally take a sip. So when you go for it, it's right there at your nose already. Ooh, that's good. So that is the Deloitte Desjardins, a little non-alcoholic, zero-proof cocktail for your summer fun or early summer fun. Yeah. Drink it all year round. Carrots are available perennially. And again, substitute what you like, play around. You know, there's no reason that these things can't be what you want them to be. Yeah.
Thank you so much for joining us. Cheers. We hope that you'll take some of these tips, and even if it's just maybe making that mint rosemary simple syrup, you could even throw it in iced tea. Make any kind of cocktail with it. It's really fantastic. So again, I'm Natasha Soto-Alborz.
And I'm Rich Strayer. It's great being here. Thanks so much.
Pleasure being with all of you, and have a wonderful evening.
Thank you, Natasha and Rich, and thank you to everyone for joining us today. We hope you have a great rest of your day.